Hello there, this is Kent Campbell here with Sheree Martinez, and we're here today doing therapist training, talking about informed consent in mental health counseling in California. This is a training video designed for therapists and graduate students who are therapists learning all about how all this works. We hope that this video will be informative and engaging. And so with that, we'll start with this first idea about informed consent. Again, this video being for marriage and family therapists, licensed professional clinical social workers, licensed professional clinical counselors. That's the target audience of folks that we're talking about. Sheree, do you want to read through our first slide?
Yeah. So there's some 3 key points that come with informed consent. The first one is a therapist communicates expectations and procedures to a client that allows the client to give their consent to participate in psychotherapy. The second is the client must understand the risks and benefits of entering into this treatment at the beginning of the work. A client needs information from the therapist to decide, and aspects of this discussion continue through the therapy process.
Exactly. To me, I really like this definition of things, that what we're saying is that for someone to make an informed decision to participate in psychotherapy, they need a lot of information from the therapist to determine whether or not therapy in general or therapy with this clinician is something that's really what they want and seek. And what we're going to talk through in this video are a lot of the nuances about that process. And the third point that Sheree read, this other aspect of things, that this is really an ongoing process. Ideally, it's something that happens at the onset of treatment, but in reality, this is something that is going to take probably more than one session to get all the way through. And as things change over the course of the treatment, different parts are going to need to be spoken to in different ways. And we'll talk about how that works. And thinking about ethics and psychotherapy, we talk a lot about the idea about what's important to therapists and the autonomy for the client, the ability of a client to make the right decisions for themselves is essential to everything. The idea that a marriage therapist doesn't tell a couple whether or not the two people should stay together or not, but rather the two people get to decide what they want for themselves. The therapist is there to help people make sense of a situation, talk, think, feel through, and talk about what different things would mean. But the value of our profession is that of autonomy, really wanting the idea for clients to make these decisions themselves. And as Sheree just read to us in our last slide, the idea is the therapist is the one who, in many circumstances, is going to hold a lot of information that the client might not have access to. And so what we want to make sure is that there's both a legal reasoning and an ethical reasoning for our community of professionals to take time to really articulate this clearly to our clients at the beginning of the practice. Sheree, do you want to talk about this idea about consent and assent?
Yeah. So in my perspective, when you're doing informed consent, it feels important to make sure that the client is competent with the information that's being provided. They have like a clear understanding. So especially when it comes to like the language used, you want to make sure that the language is appropriate for the client to where they can fully understand it. And make like an informed decision about if they want to continue with treatment or not.
Exactly. What about these ideas about assent and dissent? How do those pop in? Do you remember those?
Yeah, so assent and dissent is typically used for individuals who are either like a minor or can't really consent to treatment themselves. They can just do like a neutral agreement to continue with treatment. So you'll see these in situations where it's like with minors, with adults who are like, what would you say, like
right, under the care of a custodian, right? That
yeah, under
the make their own decisions legally.
Right, yeah. And then consent is when somebody can give full agreement on their own to treatment. And then dissent is the opposite of assent. It's just refusing treatment or not wanting to comply.
Exactly. And we talk a lot with minors about this idea about assent, that a child can't legally give permission, but they can agree that this is something that they want for themselves, want to participate in. I was researching and remembering that part of The history about where this comes from in the state of California is a case that came into the California Supreme Court in 1972 called Hobbs versus Grant. And it came from the 60s and 70s out of this idea that medical professionals and the public were wrestling with the idea about who gets to make decisions about what and how much information needs to be shared with a client before they can really agree to a treatment. And so the notion is that a medical doctor, there might be a risky procedure on someone's heart or another part of the body where there would be benefits, but also risks to such a surgery. And in 1972, the California State Supreme Court said that medical care professionals need to have their patients make an informed consent to treatment. That in the real medical world, that way means talk about the pros and cons of a procedure or different approaches and let the patient have some say in the matter. And the idea is that that kind of translates onto our world for psychotherapy, where the risks of psychotherapy in one respect are relatively minor. We're not talking about open heart surgery and the risks of such a procedure, but we are talking about really important social, emotional, relationship issues, and those can have big consequences on people's lives. And so the notion is that therapists are asked to talk about those things, but for the law, it's rather minor. The things that the law says that really need to happen is that a therapist needs to communicate a fee before the session. So I can't show up to my therapist's office and be surprised by the financial fee being charged. That has to be communicated ahead of time. The other part being the license status of the therapist. So there are trainee and associate MFTs and other licenses who are apprentices. They have not finished their licensing process. They're still under training and supervision. And a clinician in that category is legally bound to disclose that initially. And along those same lines, a licensed person should really say, I'm a licensed marriage and family therapist, and this is what I do, as opposed to being a life coach or something else, someone who's doing some different kind of work. So those parts, the law is clear that that needs to happen. And then the other piece is for someone who follows HIPAA regulations that dictate how health insurance is shared between different parties, that kind of person also has to say before the first session that they follow HIPAA policies, and a signature is needed on their privacy policy statement. Those are the ones that really matter. That's dictated in the California Business Code, and it's enforced by the Board of Behavioral Sciences. And how to file a complaint with the BBS is the other piece, that's supposed to be communicated in the process as well. But those are essentially business regulations that the BBS would enforce about that part. And that's the minimum requirement that therapists run into. In reality, the practice is to cover far more than that, but it comes from a much longer optional list that we'll get to next. The last part here says that if you don't get a signature from your patient, what the therapist should really do is indicate in the notes that these policies were explained. And that's going to be important for the client and the therapist to agree that that was covered, and including this part about the client's right to terminate treatment, that the client is the one who gets to decide when they don't need to come back anymore. You can imagine in the way that sometimes a therapist has more power in the counseling room than the client, that it's important for the client to know that they can change that interaction and end it when they decide they want to. And so that brings us to this long list of optional things. We have 4 slides here that list the different ways that therapists are by and large encouraged to communicate as part of informed consent. Not everyone has every item, but it's a long one. I'll start with this first one, the therapeutic process. And it's supposed to say, how is the time used? This notion that how is therapy supposed to work? And some of us have a hard time explaining that in a full 50-minute lecture, let alone explain this in 3 minutes to our client over the telephone before the session starts. But the idea is to be able to explain how the process is going to flow, that theoretically there would be some time for assessment to determine what's happening, goal setting to mutually decide how things are to proceed, a working stage when you're working on issues that might revert back to further goal setting and additional working stages, and ended termination. But this idea that for someone who's never had therapy before, informed consent should really include a notion about how the process should flow.
Mhm. Okay, going on to the next one, background and qualifications of the therapist. So with this, it's good to just highlight your educational background, your specializations, what you are specifically trained in, um, any kind of, uh, I would say, like where maybe you would graduate from, or also
Mhm.
your theoretical orientation that you may be implementing in with the client. Those are good things to kind of highlight and talk over with the client so they have an idea of who you are as a therapist and what they're going to kind of look forward to coming from
Mhm.
you.
You bet. And their competence, right? Like that's gonna make me
Mhm.
feel better. Yep. The third bullet, we already talked about the cost of therapy, but oftentimes there's a particular process about how fees are paid. It could be by credit card, it used to be by check. Some therapists ask for the client to make a direct deposit to the therapist's account, but part of the written informed consent process should explain how that works so that the client would know.
Mhm. The length of therapy and termination process. The length of therapy will obviously, I think, would vary like client to client. I'm not sure. Like, would you say if maybe a therapist would start off maybe with like a 3-month treatment at first? Is that a thing?
It is. It's just the way you're asking is correct. It's difficult to know, and
Yeah.
I think the more structured way I've heard is someone saying, "This is going to be an 8-week course that's going to follow this manual that's going to work on how to reduce your anxious symptoms." But by and large, several months is a pretty good guess, I
Hmm.
think, to give most people coming into most relationship dynamic kind of issues. Yeah,
Yeah. And it also probably depends on your like theoretical orientation, right? If you're
exactly.
coming from like a CBT background, sometimes it's like short-term or long-term therapy, depending on the therapist's orientation or what's right for the client. Also, I think the termination process, as said on the previous slide, is a collaboration between the therapist and the client, but more so it's put on the client to determine when they want to terminate therapy.
That's right. That's right. And as you say, that reminds me that a lot of folks in their informed consent will say, if you, the client, decide you're ready to end treatment, what I would ask for is at least one session for me, the therapist, and you, the client, and I to talk through what happened. Because sometimes, as you can imagine, and as some of us have experienced, there's conflict in a good way or a difficult way between the client and the therapist, where we're working through some interpersonal dynamics that are showing up in the room. And instead of having the client just decide, that's it, I'm not coming back anymore, therapist will say, let's have one session to talk through what just happened so that we can make an understanding of this.
Mm.
Or even if it's a good ending, we've finished our anxiety treatment, symptoms are relieved, one session to process this. The notion in part being, is there a way to make sure that the client can really deepen these results and carry it with them in other ways. The last bullet here on this page talks about confidentiality. And to me, this is this notion that the therapist and client relationship is protected by an umbrella of confidentiality, privacy, where anyone can talk about their deepest, darkest secrets and not worry about the therapist sharing that information elsewhere. That there are real strict limits to what the therapist is, by business code, allowed to say and do and talk about. The part that comes with that is the responsibility to protect the client and the public. And what that means is that if the client expresses a way that they might be a danger to themselves by being actively suicidal or otherwise, or if a client has information about other people in the world being hurt, whether it's the client being a victim or a perpetrator or intending to hurt someone, the therapist is obliged to break confidentiality to warn and protect members of the public that are not in that counseling room. That's one of the biggest ways of breaking confidentiality to protect other people. But there are other ways also that confidentiality is broken, and a client should really understand that if a client signs a form saying that the therapist has permission to talk to their insurance company or their lawyer or a teacher or a boss, the therapist would have permission to release that in a way that the client really needs to be careful about doing.
Mm.
The last piece, they're saying that it's common practice for good therapists to discuss what's happening in a session with someone else. So it's not just my brain and heart that are thinking about this, but I'm discussing this with someone else, and that there's a real value for the patient having the therapist share that information with other people. That said, when information is shared with someone else, the patient's identity is protected. You don't use their real name. You change some of the details to make it difficult to identify them. But the idea is the client should be aware that as part of therapy, there are these reasons why, limits to things being kept confidential.
Mm-hmm.
I'll say this one, that is the idea that the therapist is going to have meetings with the client on the schedule, but there are times when the therapist is not going to be available. And most therapists are not great emergency crisis people because they have lives that they're living and doing. And the therapist should communicate to a client when they're in crisis what they should do late at night or over the weekend when the therapist can't be reached. And so being able to have contact numbers of crisis lines and things like that can be really important.
Next one, frequency of meetings and potential interruptions. It's good to highlight how often therapy would take place, whether it's once a week, twice a month, and highlighting that in your informed consent document, and also letting them know in person. And the potential interruptions that come with it, that could be like emergency situations, whether it's on the therapist's part or the client's part, and what would happen in that situation. If it would be like rescheduled, or if the therapist would refer a client to see somebody else in the time being while they're absent, depending on emergencies.
Exactly. Risks and benefits, as I mentioned before, someone might want to talk about their long-term relationship, their marriage. They might want to talk about their depression. They might want to talk about their trauma history. And there could be really great benefits to discussing that with someone else in the privacy and supportive space that is psychotherapy. But there are also real risks to do that. If you talk about those things, it could be that that's going to bring up a lot of uncomfortable feelings, and it could be that it would lead to you, the client, choosing to end relationships or to really feel quite upset for some period of time. And it's appropriate for a therapist to mention that initially, to say, hey, this is by and large something that I think is going to be really good for you, but it might be, there's a risk of some pain along the way also.
For the next one, when I think of like telecommunication technology, it's not referring to not only teletherapy, but also just the communication in general, whether it's through email, text, calls. It's important to like note with the client how their privacy will be kept, I think, and to be aware of kind of like the risks that come with that, communicating over using technology and whatnot.
Exactly. To me, one I think about is LinkedIn, right? Where there are some people that I really know and like, and I would enjoy being connected with them professionally on LinkedIn. But if we're connected and someone asks me, well, how do you know this person? It's kind of harder to defend that without disclosing someone's reason for meeting with me.
Mm-hmm.
Alternatives to traditional therapy mean that part of the normal expectations of marriage and family therapists is that we don't say that therapy is the only possible solution, but that we explain to someone that it could be something very different, whether it's body oriented, like chiropractor or acupuncture, or learning meditation, or seeking assistance from a psychiatrist to take medication, that there could be other ways that this work could be accomplished besides psychotherapy. And to me, that's, again, reflecting this idea about wanting clients to have autonomy and be able to make their own decisions about what's best for them.
clients' right of access to their files. This means that clients have the right to obtain their file at any time, and it's the therapist's obligation or duty to offer that to the client. So that could include, I think, like treatment, the process of treatment, whatever's in their file, their diagnosis. Would that include the therapist's progress notes as well?
And that is where that would come from. That's right.
Yeah.
In the
Okay.
therapist's notes. Um, and that changed a lot with the way that HIPAA has really been helpful to empower clients to be able to take control of their own medical healthcare decisions. It makes it difficult for therapists, though, because there's the notion of the clinician, want to be able to think and write about what I think is happening, and some of what I think is happening, the client might not want to read, or it might not be in their best interest to read. So kind of tricky to navigate that part of it. But notes ideally will really clearly explain what happened for someone who's reading from the outside. And again, those
Mhm.
notes are something that say confidential and private.
Yeah.
Along those lines, there's the idea that a client should really be able to know what their psychiatric diagnosis is. So if they do meet criteria for being depressed or anxious or obsessive compulsive, the idea is that a client should be able to ask about that, and the therapist should communicate that they want to let them know what that is, unless under some rare circumstance that would be somehow unhelpful to the client. And it's hard for me to think about what such a circumstance would be, because even a severe diagnosis would mean that the client should really have that information to make the healthcare decisions they need.
Mhm. Um, I mentioned it previously, but the language when it comes to informed consent needs to be in a way where they understand it. And try not like sometimes informed consents can sound really wordy and professional, and clients can sometimes not really understand those big terms that we use in our informed consent. So it's a good way to make sure that they're able to fully understand what they're signing up for.
Exactly. An important part for therapists is to make sure that they're clear with their clients about what the expectations are about cancellations and how to handle times when people are not able to meet. One of the hardest parts for therapists in private practice and otherwise is when their clients don't show up. I've been at schools where I've been waiting for clients to arrive for a long time, and it's frustrating to not know what's happening. I've been in private practice where a client doesn't make it, and for a therapist not to know is it's hard to know how to spend that time when you want to be efficient and providing care for people. And so the idea is that in informed consent, a therapist would be clear about what kind of policies are expected. Hey, client, I'd like you to know that I have a 24-hour cancellation policy. I require you tell me 24 hours in advance if you need to do something different. And there are good reasons why a client is not going to be in the office, and whether it's being ill or taking care of a loved one, a last business meeting that shows up, there are reasons why we have to accommodate changes, but it should be clear what the procedure and policies would be about that. And usually what that means is looking to reschedule so the client and therapist can have that time that week, with this part about letting the therapist know with as much time as possible.
Mm. Working with insurance providers. If I think like if you're a therapist and you're working with insurance providers, it's a good thing to make that well aware for the client. I'm not sure if uh, therapists need to like list the insurances that they work for, but if they
Mhm.
do, like list their policies when it comes to like reimbursement, offering that to your clients, or um, would this be like a good area to also list HIPAA since you're working would be
Exactly.
sharing medical documents with them?
That's right. And talking that part through. And in fact, that even would be a separate document about setting the privacy policies. But you're right to talk about these are the panels that I work with, or for the panels I'm not on, this is the practice about how to get a super bill to get reimbursed. And you, the client, have the pleasure of dealing with the insurance company to request that. Yep.
Mm.
And these days I mentioned LinkedIn, this idea about social media policies. The common practice I've seen there is for us to say, we're not going to be friends on social media. And if you request to be friends, I'm just going to ignore it, but to talk about why. And again, goes back to that privacy idea, usually about the therapist having their own private life and the client not having their confidentiality broken by being connected with the therapist.
Mhm. Handling meeting somebody outside of a session. So when I think of this, I think of like seeing a client when you're walking down the aisle at a grocery store or something like that.
Mhm.
The best thing to keep in mind is keeping their privacy private and their confidentiality. I think in this situation, I would probably not engage first. If the client was to see me, I would let them say hi first and then professionally and politely say hi and then kind of make it short and sweet.
Mhm.
Um, you don't want to kind of have a long meeting outside of therapy in the middle of the grocery store. You risk breaking that confidentiality and privacy, especially if you're with somebody and that person says, "Hey, like who was that?" And then you can't disclose that information with that
That's right.
person. So,
And then there's also the fun part being the client who sees my therapist. It's kind of exciting, and I want to be acknowledged. I don't want to be ignored. When that's happened to me before, and so the idea about being, yeah, polite and reciprocal, you bet,
mhm,
makes a difference. Working with minors, we talked about the idea about assent and this idea that once a child is 12 years of age or older, they have more legal rights to ask for their own treatment without their parents being involved or with their parents being involved. But that the law makes a difference between someone who's 12 through 17, saying that they have certain um, rights to request therapy, even if adults in their lives are not really in favor of that. And what that means is it's usually the parent that brings the child into therapy. The therapist and parent have to have discussions about um, who's giving consent and what this is for, and how to work with that part. And I think I'll talk about the next one also, which means that what we want to talk about in that conversation between the therapist and the parents are, or the guardians, what are the expectations about privacy for the client? And what to me that means is that a child who is 6 years old, expects the therapist to tell the parents everything that happened in the session. And a little kid is probably going to go home and talk about everything that they did in session. We played in the sand and we made a drawing and we talked about, the fear monster. That's really common for there not to be much privacy that way. But when the patient is a teenager, there's a greater expectation that the parents will tolerate the child having some degree of privacy, and that the details of the content of what's being discussed really won't be shared with the parents as much. Sometimes that's easier to manage than others. A lot of times it's easy because the child is working through their issues and working on growing up, and the parent wants the child to have that space. And it's harder when the parents are really concerned about their young one or their teenage one, and when a teenager is engaging in behaviors that the parents wouldn't approve of. It is difficult to figure out where to draw those lines, and much easier if this is part of the initial informed consent process to explain than if your therapist waits until later to deal with it.
mm. Um, Handling complaints. I think with this section, it was talking about like listing in the informed consent where the client can file a complaint against their therapist if they did have one. So they have that right to kind of report any kind of like suspicious activity or something that they don't like that may be violating some sort of ethics code. It's in the informed consent and also communicating that with your client. It's a good way to allow them to let them know so they're knowledge like competent in that area. They need to
Exactly.
report something.
Mhm.
Yeah.
With couples, kind of like with a child, confidentiality tends to be complicated. That when it's just one person in the room with the therapist, it's very clear that everything we talk about will stay here between the two of us. When there are three people in the room, um, those two people have to figure out how to make sure that they're keeping the content of the discussions safe and private. And even worse, if one person is not in the room and the therapist is talking with one person from the couple and their partner is not in the room listening, what happens with that information? Does that stay private between those two, or does it get shared with those three when the partner comes back in?
Mhm,
And so some folks even have a separate informed consent document just for couples to talk through those nuances.
mhm,
The idea being we want to guarantee privacy, and usually it's not appropriate for a therapist to be holding secrets and to be more on one person's side than another. But the idea we want to try to be sharing all things together. It doesn't always work, but that's the general idea.
It sounds like it's best to just keep like a no secret policy in place.
That and from my perspective, having almost all the meetings where everyone is present. And
Yeah.
so last week for my couple that didn't arrive on time and they came in 2 different vehicles, one person waited in the waiting room an extra 10 minutes until their partner got there. And that way there's no worry about who's saying what when.
Yeah. Trainees and associates discussion with supervisors. So when you're like working in practicum, or if you're like on field site, working with clients, it should be made known with your client that you'll be discussing cases with your supervisors, but you'll also be doing it in the best interest of the client and keeping their privacy private. And yeah, so trainees and associates would be discussing, that's part of their responsibilities, is discussing cases with their supervisors and consulting with them to kind of develop in their profession.
It's true. And there's even a release information form if your supervisor isn't right there on site. That's made really clear now to clients, which I think is important. Bringing in outside voices to treatment, to me, is this idea that it could be that I'm the therapist meeting with one client for one period of time, and it could be that they want me to speak with their doctor or with the child's teacher, or that the client wants individual treatment to become couples treatment where there's someone else in the room also. And to me, the part to kind of articulate here is the notion that when any of those kind of breaches of confidentiality happen, the client needs to really understand what that means. The client needs to give consent to say, I really do want you to speak with this person. And it's okay if they know that I'm in therapy working on my whatever issue.
Mm-hmm.
And to talk with the client about how things might change if suddenly we're doing family therapy instead of me just supporting them. So again, giving the client information and talking about risks and benefits so that the client can make a real good decision.
Theoretical orientation of a therapist. So informing your client of what your approach is to therapy. So whether that be like CBT or psychodynamic or existential, giving the client like a little bit of background information about what your approach will be to their treatment, what the process will be like. So they just have like a better idea of what to look forward to when working with you as a therapist. Yeah.
Exactly. And then our last one for this is this idea about gift giving and receiving. Ethically, therapists need to be careful about receiving gifts, both for monetary value and what that's communicating, but also just looking at messages and intention and what the meaning of certain communications are. There are times at certain times of the year with certain holidays and certain people, I think it's appropriate to receive a gift, or even for a therapist to give a simple token of a gift that communicates fondness and that things are going well. But it's more complicated if clients want to give therapists gifts that have high value or communicate certain messages. And so for a therapist to explain in their initial informed consent document that I just don't receive gifts and I just want you to know it, that kind of clarity can be really helpful to avoid any misunderstanding. Kind of like seeing someone in person and being ignored in public. To give a gift and have the therapist say, I can't accept that. So it's a difficult place to be in.
Mm-hmm. And also, I think depending on the culture too, some cultural values also highly, their way of expressing is through gift giving. And if you turn it down, it's seen as disrespectful in some cultures. Sometimes cultures even love to share food as a means of kind of spreading or sharing their values or whatever. So it's good to keep in some cultural values as well in mind.
Right. And we've shared stories about that before too. And that all of these really can be impacted by making sure you have a multicultural perspective on. Different people are going to hear these messages in different ways, and so to consider how they're being received and make sure you're paying attention to who's there in front of you. And so as I made this long list, I thought to myself, my goodness, how is a therapist really supposed to communicate all of this at once? There's so much material there. I think about pages and pages of consent forms it would take to really communicate all of this clearly and effectively. And I think about how that's burdensome for a client to really read through and understand. And even if I read something at the beginning of my work with my therapist, am I going to remember it at the end? And so we kind of, I think, share this idea that we're to do our best job to communicate those things that are of the utmost importance and look along the ways to communicate to the client what our expectations are as therapists, and that the idea is that this should be an ongoing communication, that there are lots of different aspects of this. We have to balance communicating the details of this with the idea about treatment and having the client get to work on what they really want to pay attention to.
Mm-hmm.
One of the challenges can be to figure out how much time as a therapist to spend in session talking about these things versus hearing the client's story.
I think there's some like dilemmas that you can get into where a client may come in like distressed even, or just really needing someone to like listen to them. And so it's sometimes not the appropriate time to right away try and talk about informed consent when you really need to just focus on what's best for the client and what they need in that moment.
Exactly. Exactly. Which puts the therapist in an uncomfortable position a little bit, because part of me knows I'm supposed to get this covered. But in, for example, the case here with Gloria and George, it's just what Cherie's describing. The therapist's responsibility is to meet the client where they are and make sure that the client gets the care that they need at that time. For sharing informed consent, it used to be that there was a stack of paperwork that folks would kind of expect at the beginning of counseling time. Now, more often than not, I think that a lot of these forms are shared online. The advantage of an online form is that it's immediate, can be stored online, and hopefully can be read through and referred back to. Paper forms tend to be much more tangible, get a wet signature to really talk through the details, but those oftentimes can be lost and misplaced. The notion is that what you want to do as a therapist is to have a system that's going to work for you to communicate all these pieces. And again, whether there's a signature on the paper or not, we want to make sure in our notes we're really describing that we've covered this information. Do you remember this one, Sri? Do you want to explain this idea?
Oh, so this was similar to almost the last one. There was a client who was kind of in a crisis situation who showed up and was presenting some issues with having some schizophrenia and not being on his medication. And so he was exhibiting some of those symptoms where he really needed the therapist to be present with him in that moment and kind of get a safety plan in the way and help him through that issue before trying to implement informed consent. And so,
Exactly.
yeah.
Exactly. And kind of echoing, just like you said, your previous example, this idea that meet the client where they are, and if a client is not in the space where they can competently consent anyway, that's not going to make a difference. They need to be in a good place to really understand. And so up to us to figure out how to pay attention to these parts. One of our last slides here, the challenges to informed consent, ideas about what makes it difficult. And we just talked about one. If there is an adult who is either not in a space where they're able to be making good decisions, or they've been declared by a court not competent, not allowed to make their own decisions, right? There have been some famous folks in broader culture who have had the court say, your parent is the one who's going to decide this for you. That person would not legally be able to consent to things. An emancipated minor is the idea that there could be a minor, someone who's under the age of 18, who's by a judge been granted the right to be considered legally an adult. We should know that they can consent to their own treatment. And a mature minor would be someone who is 12 years old or older and is expressing a real desire to talk about something, and they're asking for help. They're demonstrating they can benefit from this treatment. They have a right to say things. I mentioned how parents usually are the ones who give consent for treatment to minors, even when they're 12 and older. Usually it's the parents who really are the ones who agree to that. And it could also be that a client would come in and say that they don't agree and they want something different. There was a patient who came in and saw a therapist this week, and the patient said in a couples session, the one person said, "I want you to refer me to, or I want you to be a private investigator, and I want you to tell me if my partner had an affair or not." And the therapist said, "I really appreciate that that's something that you really want an answer for, and that this is really difficult for you, but that's not something that I can do. I can help you process your feelings, but I can't tell you whether or not this affair happened with a firm stamp or not."
Mm-hmm.
And so to me, that was an example of how the client was deciding not to consent. They wanted something different. So that you all know, one of the great resources for therapists in training is the CAMPT website. It lists a ton of the different articles that have been published through the CAMPT magazine, and this one, Revisiting Informed Consent, that Michael Griffin wrote, is one that I'd recommend reading to get more of these ideas. We did our best to cover the essence of them, and that's going to be a good resource for folks who want to learn more about this. Well, here's to all of us continuing learning on our journey, and thanks to Cherie, and best luck to all of you out there. Thanks for watching.